An awful lot of the health care that's consumed is actually consumed by a very small percentage of our population. Those among us who have multiple illnesses, many chronic illnesses, who live under conditions of social stress, poverty, disadvantage, the consequences of inequality and even racism in society. That's a small proportion of our population. You can cut it any way you want, but probably 5% of the people in our nation use half the care.
I think a lot of times people don't know anything about healthcare, and they will talk about socialized medicine or a single payer system, and shouldn't we do this? And no, that's crazy, and we need a free market. I think this is a lot of noise. I don't think that's actually really helpful or useful. I think what is helpful and useful to know is that we spend so much money and we're not getting the best quality for that money. Now what?
For the people who have complex care needs, a lot of the issues are around fragmentation, the siloing of services, and in some cases, the absence or lack of the services that people actually need to be healthy.
There is so much uncertainty. Organizations have to keep their heads down and just do their work, because who knows how things are going to play out and what the time frame is going to look like.
We're going to bend the cost curve in America. We're going to make care more humane, more patient-centered. We're going to end homelessness. The idea that people went to the hospital to get out of the rain will end. We landed people on the moon, can't we end? Like 80-year-olds living on park benches in front of hospitals?
In the United States, just 5% of patients account for 50% of the cost of care. This is especially true for low-income communities like Camden, New Jersey, where 95% of residents are eligible for Medicaid, and where families struggle to get ahead of the city's reputation for crime and poverty. How to more effectively care for a population with complex health and social needs has fallen largely on the shoulders of a coalition of a few organizations, willing clinicians, and thoughtful caregivers. One early innovator is finally gaining traction and support in their delivery of population health-based programs. Since 2002, the Camden Coalition of Healthcare Providers has successfully used hotspotting to focus their care management teams and to better understand who in the community needs the most help.
The city is very small, 9 square miles, roughly about 80,000 people. And in my opinion, people are only about 2 people removed from knowing someone. Over the years, the city has been met with many challenges. The criminal justice system, education system, and even leadership has struggled. The national impression of Camden is oftentimes, a community that's being torn or ripped apart, poverty, trauma, its impact. Residents are oftentimes disengaged, not invested. A lot of the struggles that people face on a day-to-day basis are common struggles, but as you begin to work with people and really understand the people and their needs, a totally different story comes up. And it's really just understanding the story of people. And so the Camden Coalition being in a position really to amplify those struggles and not just bring attention to them, but also put ourselves in a position so as to meet person's needs.
So there's 2 wonderful words. There's complex and complicated, and they're totally different words. So the complicated is a watch. And I don't know how watches work. You take the back of the watch off, you look at it, it's like a lot of gears and gizmos and mechanisms. It looks really cool, but I have no idea how it works. But you could take the watch apart and put it back together. That's complicated. Complex are systems that are so interdependent that you can't take them apart and put them back together. Our patients, particularly ones with many issues, are not complicated, they're complex. And what that means is that there's a lot of drivers and a lot of issues that are all being threaded together and making it very challenging for us to take care of them.
The thing we're trying to do is create a healthcare system that allows for people to have equity. 1, empower them to feel like they do have a choice, but 2, make them not feel like they're a victim of the healthcare system, but a part of it. It started really with those patients that were admitted to the hospital over and over. And this subset of patients were really complex, and they were found to really live in certain locations within the city, not just those that were admitted over and over, but maybe those that end up in the emergency department too often, or maybe those that aren't getting enough health care. And so the focus that we have now is identifying really all of the subsets of patients that create this complexity within that 5% that equal that 50% of healthcare dollars. That group is varied, but definable. And so we're defining that group in such a way that we can come up with interventions that can be standardized and find solutions that the framework can be applied everywhere. I'd say that's really the mission of what we do on a regular basis, is to empower the patient and the provider to work together for better healthcare.
Every morning, care teams and data analysts at the Coalition pore over reports generated by the Camden Health Information Exchange. This exchange combines real-time data from the region's major health systems and is used by the Camden Coalition, local primary care offices, and hospital staff to better coordinate care throughout the city. Their goal is simple: identify candidates for the Coalition's programs, make a bedside invitation to enroll, and schedule a time to follow up within 7 days of discharge. This process is also referred to as hotspotting.
All right, let's read it aloud one more time. We will assure that X% of eligible individuals have a collaborative...
So hotspotting is really saying who are the people in a community that need the most resource, and it's using data. It could be a data metric that you pick. Ours is frequency. So we say, how many times have you been going to the hospital? And you pick somebody off that list. It's using data in a way to actually lift up people's stories, identify what's already working for them and what resources exist in the community, and then filling the gaps of those that don't.
In building this health information exchange and being able to use data and engagement together, we've been able to see really powerful results. So it's really about using data to figure out where are the folks, who are the folks who are most in need, and how do we devote more resources to those patients.
For me, care management really is about building support, putting the emphasis on care, that somebody cares and somebody is invested in how you're doing. And it seems like you may feel a little overwhelmed. There are things that you're identifying that you'd like to address. For some, it may just be, I got an ID. I haven't had an ID in a decade. And for somebody else, it may be get off the streets and reconnecting somebody to their family. So I think success really needs to be defined as what an individual sees for themselves, not necessarily what we as the coalition or as a medical provider think that needs to happen in order to keep them out of the hospital or get them to the doctor. For each individual, it may look different, and we want to recognize that and respect that and help them meet their goals.
I was out on the corner selling drugs, getting high. You know, that was my addiction, heroin. We don't live in a realistic world when you're an addict. You know, everything to us is to get high, and if one's not getting high, anything else around them doesn't matter at all, you know. I needed someone to believe in me. You know, I needed hope, I needed faith within myself. Change is not easy. You know, there's gonna be some obstacles, but you know, I couldn't let the obstacles in my way affect me and me go back to what I used to do.
This is Brian. Brian, this is Miguel. He's one of our new community health workers.
I was thinking in terms like, okay, you know, when I was willing to just throw my hands in and say, you know, I can't do this, you know, Bill was there to show me another side, you know what I mean? And you know, bring me back into reality, you know. And if it wasn't for him, you know, and the way he spoke to me, I wouldn't even be here.
I think one of the things that the Camden Coalition can do and has done is it's amplified a voice that's often been unheard, completely unheard, people who are really invisible. And in a way, this movement that the coalition sort of symbolizes is saying, we want to do something about that.
One of the things that stands out for the Camden Coalition is the recognition that we need to take data from beyond the healthcare system. Are individuals getting housed? Are they staying out of jail? Are they getting the access to the food and other social service supports that they need, and so forth?
In particular, when you're taking care of people with complex care needs, you need to listen to them. They have the experience of what has worked, what hasn't worked, what are the barriers for them to be healthy. And your care team would be very well served by listening and learning from that knowledge.
We now know so much more about social determinants of illness, housing, transportation, nutrition, inequity, violence. The Camden Coalition, in the company of a few other pioneers, is really showing how extraordinary the results can be when we begin to work on these generators of thriving instead of just giving out the pills.
In Doylestown, Pennsylvania, just 40 miles north of Camden, a different organization has spent the last 16 years researching, developing, and deploying advanced preventive care models for another group of complex patients, the elderly. With this data-driven approach, Health Quality Partners has managed to reduce mortality across their patient population by 25%. But Dr. Coburn's story isn't rooted in rural Pennsylvania. It began during his time as a young doctor serving on the front lines of the 1980s HIV/AIDS epidemic in New York City. Together with an ad hoc group of nurses, social workers, physicians, community workers, and others, their work would help transform not only HIV/AIDS care, but would lay the foundation for the population health-based care management Dr. Coburn practices today.
Acquired immune deficiency syndrome, or AIDS for short, was first identified about 18 months ago. The disease can take a few weeks or up to 2 years to develop, and diagnosis is frequently difficult.
Mid to late 80s, early 1990s, right around the peak of the AIDS epidemic. So it was the height of the suffering, the public health crisis, the lack of good therapies and treatments. New York State tried to organize itself as best it could to bring good quality care to that population. So they created a system of designated AIDS centers that included a multidisciplinary team of people, HIV tester counselors, community health workers, nurses, docs, social workers. And I didn't realize as a young doc how radical a way of working as a team that was. But despite having very poor medications at the time and ineffective treatments, we could really get out into the communities and in the homes and improve care and sometimes even health outcomes against a very kind of devastating disease. So that was kind of my imprinting that said, if you can identify the people who need you the most and work in creative teams that can bring a whole system, whole person approach to the care, you can make a very big difference. So Health Quality Partners has generally, our staffing level has been between 20 and 24 folks, most of them nurses. We have data analytic folks and outreach specialists for enrolling and engaging with both practices and patients. We've generally served 6 or 7 counties in southeastern Pennsylvania, and at any given time we've had up to as many as 1,000 active participants in the program over the years. Right now we're at about 550 or so active participants, and expect that to grow depending on who we're partnering with at any given time. Hotspotting is a very useful construct to think about in terms of how we build systems to relate to folks, engage them, identify other issues in their lives that represent failures of healthcare and or challenges to their health outcomes. If it will work for them, that population of so-called superutilizers, through a hotspotting process whereby you identify who they are and engage them, it will have the attributes it needs to work for a larger vulnerable population. Every night, we pull data from the electronic medical records of the primary care docs affiliated with the system, and every night we recalculate a risk score. So that's fresh every morning on 172,000 unique people that live in the community, so it's totally community-based, and it lists their chronic conditions and whether their risk has changed overnight based on labs or an event that they had going to the ER or whatever. So it's a totally different way of using data than waiting to decide at the end of the year, did we save money?
The flag flew at half-staff today at Ryan White's Indiana High School. The 18-year-old AIDS patient died of a respiratory ailment related to AIDS on Sunday.
Sometimes, to be honest with you, I get kind of choked up still from the old days. Young people dying shouldn't have been dying. I think the thing, that is a theme through all of those vignettes, those individual stories, is the idea that together, if you're really engaged and trying to look outward and be aware of the total context of people's lives, and you have a team of people who are good at doing that and dedicated to that, that bring different perspectives from their own lives. The folks who live in those neighborhoods, the folks who, went to med school, and everybody in between, we can do the most for that population.
While much of the innovation around complex care has occurred within targeted, low-income populations, larger systems providing services in urban and suburban communities are discovering how to dramatically scale their care management efforts. Founded in 1994 by Brigham and Women's Hospital and Mass General, Partners Healthcare employs more than 60,000 people and serves 80% of the state's 7 million residents.
Matching what services we can bring to our patients to the patient's needs is a constant struggle. Partners has 600,000 patients in risk contracts and about 1.2 million patients that we are the primary caregivers for. And so we have about 20,000 high-risk patients. And because we're doing it over the whole population and not a specific subset, delivering the services for example, an elderly patient with dementia and a pediatric patient with a tracheostomy, right? Those are really different service needs. And we're trying to do both, right? We're trying to cover the whole spectrum of the highest risk, highest cost patients. And the critical element in making sure that we're delivering on that promise is data.
The data will set you free. I say that somewhat tongue-in-cheek, but I think that much of the work that we do is informed by the data that we receive. It becomes extremely valuable to have that information available to you, both for some of your real-time decisions, so knowing who's in the hospital when, knowing when they're discharged from the hospital and to where, is information that is going to affect the way that your teams do their work on a regular basis. Coming in, okay? All right. Knowing how you've done and how you are doing in terms of making changes around, let's say, reaching out to patients who don't have good diabetic glycemic control or who do not have well-controlled hypertension is important as well, because that represents kind of a medium-term strategy. Having data to tell you whether your programs are successful in the long term is also extremely important, because if you don't have that data, you can't make good decisions about whether a program, which could be quite expensive, quite frankly, is worth continuing.
We had a 4% lower mortality in our care management group than a matched comparison group. That's rather remarkable. There have been very few New England Journal papers in the last decade that have shown a 4% mortality difference in a pill. If there was a 4% mortality difference in a pill, people would be clamoring to pay for it, and they wouldn't be asking for ROI, right? It would be worth paying for on its face. I think sometimes people lose sight of the benefits here. I don't mind being held to a higher standard, that there must be a return on investment. I think that keeps us working hard to try to make what we do more effective and more efficient. But stepping back from it, it's reassuring to know that this stuff is probably worth it just on its face, even without the ROI.
What we need is healthcare redefined, where we work on health across all the boundaries.
What's happening here in Camden and around the country are the emergence of programs that are really trying to get to those root causes, to address the social determinants of health, to reconnect people with family members, to help build relationships, to help build community connectedness, because fundamentally, that is what this work is all about.
But if we put an all-in effort to get everybody into healthcare, treat addiction and behavioral health and chronic pain and cognitive disorders no differently than hypertension or diabetes, then ultimately 5, 10, 15 years down the road, Every generation next would not only have longer lives, but cheaper healthcare bills, because we would have prevented those things that we could to the maximum level that we could have.
When you look at what it is that people actually need versus what they're actually getting, there's some real opportunity to focus in on the factors that are really impacting their health and their cost.
Does success look like we're improving people's health for this amount of money, and we're spending this amount of money in their homes with them, providing them with new ways to think about what health is and be more preventative? Or do we want to spend that money on people going to the ER again and again?
The idea behind population health is to keep the beds empty. And in the C-suite and the boardroom, the question is, are they buying that? Or are they still assuming that they can keep all their beds full? And some organizations are courageous enough or tolerant enough to invite that tension internally and make some changes.
Hospitals need to reinvent themselves. And what you're going to see is more and more of those services being outpatient services and fewer hospital beds, and only the sickest people in the hospital beds. That's happening. We're in the middle of that revolution right now. The places that understand that and can jump ahead of it are going to leap to the next model, and the places that hold on are going to go out of business.